for you as well, talking about nutrition in this country and how important nutrition is as we think about the development of the country and its youngsters as well as the adults. And yesterday was a very good day, those of you who were here. And today we're going to pick up some of the themes of yesterday and come into new ones. The first session is going to be on nutrition, and there are 3 presentations. As we did yesterday, we will have each of the presentations sequentially, and we'll save the questions and discussion until the end of the 3 projects. So save your questions, write them down, and hopefully we'll have time to have a good discussion about them. The first presentation is going to be a life cycle approach to obesity and prevention, and Sharon Ekabus is going to start the morning off with that presentation. I think we're ready, Sharon?
Okay. Good morning, everyone. I'm going to try to do something different, to use the board and then a few slides. The reason I'm doing this, I think some of the ideas are easy to explain by the board rather than slides. Number 1, we're talking mostly this morning about obesity, and the main reason we're focusing on obesity is because of the health risks. In adults, we see a curve that looks something like this, where at low weights, we see an increase in mortality. Then there's a point of what we consider healthful weights, and then at a certain point in the BMI, the mortality risks go up, and Dr. Bilezikian will talk about why some of those risks go up, and Dr. Deckelbaum will also. We see a similar curve, right, in children. If there's stunting and low birth weight, things like that, you see the mortality go up in the low range. There's a range of ideal birth weight, we'll come back to that later, and then at very high birth weights, mostly because the mother has had something like gestational diabetes, the risks go up again. So that's why we're concerned. We're here talking about obesity because of the associated health risks. And we're talking about obesity because the rates of obesity all over the world are increasing at very high rates. And I want to focus on what we think are some of the reasons for that. So to get ourselves in the mindset of how complicated it is, why are obesity rates changing so rapidly, I want to ask you a few questions. If I was to put here eye color and ask you where I should put, is our genes responsible for our eye color, or are environmental factors responsible for our eye color? Where should I put the mark? Okay, only if I can change like the lens color, you know, I can change the way you see my eyes, but I don't change the eye color. What if I put height here? Where should I put the mark? Both. So should I put it here? Okay, so I'm going to do this faster than I usually do. It's an interaction between our genes and our environment. When Kim said that I'm one of 8 children, and that I had always wanted to be a basketball player, I wanted to be taller, and that my parents loved me very much and they fed me very well. No matter how well they fed me, there was not a height that I could go above. It was my genetic potential. I reached my genetic potential. There was nothing in the environment that could make me break that ceiling. If I had grown up in a place where there wasn't enough food for the 8 children, the environment could have affected my genes, right? So I could have been even smaller than my midget, 5'3" right? So the environment, in the case of height, can lead us so that we don't reach our genetic potential, but our environment can't trump our genetic potential. So it does have this interaction, and it's different than weight. Where should I put the X for weight? Okay, so this is a whole life course. We teach an entire course on obesity for where we should actually put that X. But the example I just gave you, that the environment can lead to my not reaching my genetic potential height, but it can't make me go above my genetic potential height. That's not the case for weight. In the case of weight, the environment can trump genes. You can, if you have too little food, you won't reach the genetically potential weight that you would if you had enough food. And if you have too much food, you can go above the genetic potential. So that's an important concept and one that we should be thinking about. The other challenge to look at is that the relationship between weight and time is very much influenced by our genes and then the environment that we're in. I want to give you a few examples with animals. If we take an animal and we feed it a very unpalatable, monotonous diet, it's a chow diet, and the animal we're going to start with is genetically lean, then what we would see over time with the animal would gain weight, and with age the weight would stay stable. So let's use circles for the lean, chow-fed animal. If we took the same animal, the same genes, and we put it into a very, very highly processed food environment, the weight would go up like that. It would still level off. And if we wanted the animal to lose weight, in general, we could put it back on the chow and it would come back onto its curve. In animals, we can do these experiments. We can change one gene and we can change the whole shape of this curve. If we had now instead a genetically obese animal on a chow diet, on the same chow diet, it would start out at a higher weight. So the same food in a genetically obese animal, the weight difference would be throughout the life, and the other thing we see is the weight would just keep going up. If we put the obese animal now on a very highly palatable diet, it's called a supermarket diet, then we see what we see in the population now. The weights go way up, and they just continue to go up. And there are many things we can learn from these animal experiments when we change the diet back to the chow, it comes down, but it doesn't come down to the lean animal's weight. When we use physical activity, you see differences in the lean and the genetically obese. So these interactions that we see in animals, we have in ourselves. It's just not usually one gene. Many, many genes contribute in us to differences in weight and differences in susceptibility to gaining weight. So when we work with different people whose families have a family history of easily gaining weight, we have to be more concerned and more aggressive about prevention in those cases. And one of the reasons we have to be very aggressive about prevention is that once weight is accrued, once a person starts to gain weight, they defend that weight aggressively. And they defend the weight whether they come up to 400 pounds and they lose 10% of the weight, so that, I'm sorry, I'm using pounds, sorry, but 400, so 10% of 400 is 40, they come to 360. They will work towards going back up to 400. Their metabolic rate will change, their activity will change, their appetite will change to try to get back up to 400. just like if someone was 100 pounds and went to 90. The same processes in the brain kick in. We don't have time to talk about why, but that's what's very clear and very well studied at Columbia University. And that's why in most people, probably the estimates are 4 out of 5 people who lose weight regain the weight within usually 2 years or 5 years. So weight loss in any study, if it goes to 6 months, no matter how you do it, on a low-calorie diet, if you fast, no matter how you do it, almost everybody is successful to some extent in that 6-month period. And then what we see is that in some amount of time, they can maintain the weight. With time, there's a slow, gradual regain of the weight in the majority of people. Another reason why it's so important for us to focus on prevention. So when we put this conference together and this talk together, we are focusing on things that include, I'll come back to this grandparent effect, the pre-pregnancy weight, the weight gain during pregnancy, optimal birth weight, and weight gain. I want to just start with the grandparent effect. When I was pregnant with my daughter, she was developing her eggs when she was in utero with me. So the intrauterine environment that she was seeing, my grandchildren were seeing. And there's an entire field of epigenetics, which is looking at influences during pregnancy on the offspring and then a grandparent effect. Very, very important for anyone who works with adolescents and women of childbearing age. Because what happens during pregnancy can set the stage for life. So one of the things to focus on is getting the adolescent during the pre-pregnancy period, even going before the first 1,000 days, coming into the pregnancy with a full tank of iron, a full tank of folate, a full tank of all of the micronutrients, and at a desirable weight. And then in the slides that I'm not going to show you the slides, I'm going to give you the slides, it gives you very specific information about what is a good weight gain during pregnancy. If the woman starts out underweight, then it's best for her to gain more weight than a woman who starts out normal weight. There's an amount she should gain, and if the woman starts out overweight or obese, she should gain a little less. Because all of the weight gains during pregnancy that are recommended lead us to an optimal birth weight. And an optimal birth weight, based on most data, is 3,500 to 4,500 grams, which in some countries would make the baby look like a gorilla. But that is the lowest mortality and morbidity, 3,500 to 4,500 grams. And the place we get into trouble is in the big babies whose mothers have diabetes or some other metabolic problem. And so working with the mother is critical during that time. So I hope with these brief comments I've emphasized why it's important to take a life cycle approach, why prevention is so important, and now I want to leave you with something that we can do today. Right here in Yerevan. Just like I saw that your food supply is so if I was going to make a country, and I would make a country with a food supply similar to yours and just more available and accessible to more people. You see desktop, I know I'm only kidding, I see it. Okay, folders. Libraries? Gotcha. I do anything Kim tells me to do. Thank you. It's very helpful. I'm telling you, really. Okay, so these are the slides you're going to get, but I'm not going to go through them with you. They give you all the information I gave you and more extensively, but the last thing I want to take you to is the fact that physical activity is one of the most critical things you can do and you can encourage people with whom you work to do. The kinds of changes we've seen in obesity have to be related to environmental factors because the changes have happened in the last 100 years and our genes have not changed in the last 100 years. So there are many, many components to environmental things that we're not going to focus on, but campaigns in the United States look at environmental factors and understand that weight change is not a matter of willpower. And we can talk about that during the discussion more, but the emphases are on making the healthy choice the easy choice. And these are data to show that with physical activity at any weight, by being physically fit and physically active, you reduce your mortality. So if you look at these lines, which shows the fit people, people with the higher body weights who are fit have a lower mortality than people who are at the lower weights who are unfit. A critical idea, and it doesn't take much physical activity to change some of the comorbidities associated. So here's your beautiful country, and I don't know if you can see this woman. Oh, this didn't come out well at all. I'm sorry. I took this woman's picture because she has no shoes on. She's walking up those wonderful steps with no shoes on. It was early in the morning, and it emphasizes the idea that you're never too old for physical activity. This shows us that at any age, fitness reduces all-cause mortality, and it doesn't matter how old you are. So Dr. Bilaziki and Deckelbaum are going to focus on some of the comorbidities associated with obesity. They include many. And if we just substitute in that center circle in activity, we see the same comorbidities. And one approach, if it is difficult for someone to lose weight, is to help them become more active because activity changes all of these risk factors. So something that you can do immediately, even if weight loss is too difficult for people with whom you work, at any age, at any weight, helping people to become physically active is what we want, and you have everything you need to make that happen. These are pictures I took this morning that you preserve safe and sacred spaces. I saw that there are security guards in most of these places, making it possible for people to be at these places early in the morning. This is a yoga class at the same park. I'm not sure which park it was. And I think one of the things that we really would want to encourage you to do is think about these options and give yourself a lot of credit for working with extremely, extremely difficult things, for being here, focusing on these challenges, and we would encourage you to take one step at a time. Thank you.
This one? Kim, is this right? Yeah, thank you. Okay. Sharon, thank you very much. That was a very good introduction. And I'm going to follow this by discussing diabetes. I guess as obesity is an important problem in the world, so is diabetes, and I'm going to try to illustrate how, in a way, they are interconnected. I am not going to cover this entire outline. It would take the rest of the day, but I'm just going to touch on some of the high points related to some of these aspects of diabetes. These numbers are really staggering. 366 million people had diabetes in the world just a few years ago. And over the next, how many years? 15 years, we're going to see an increase to 552 million. There are only 6 billion or 7 billion people in the world. Every country in the world is showing an increase in numbers of people with diabetes. And interestingly, 80% of people with diabetes live in low and middle income countries. The typical age of the person who develops type 2 diabetes is between 40 and 59 years of age. Also of interest, there are many individuals with diabetes who don't even know they have diabetes. And depending upon the country, it could be as many as 50% of the diabetic population isn't yet recognized to have diabetes. Diabetes is associated with many, many comorbidities, including death and mortality. 4.6 million deaths a few years ago. And the costs of this disease and the comorbidities associated with it in the United States, these are numbers that even for us are hard to conceive. $465 billion US dollars a few years ago. And 11% of our health bill in the US is related to the complications of diabetes. And these numbers are increasing every year. Now this slide is hard to see. It just takes the globe and talks about the recognized and unrecognized diabetes, and you can see where we are here in Armenia. Doesn't matter. About 30 to 50% of individuals who have diabetes don't know about it. And then take some of the countries that have the highest prevalence of diabetes. Take China. There are 92 million people in China who have diabetes. Now consider the population of China, which is about 1 billion or 1.1 billion. They're beginning to see how common, and the numbers. India, 62 billion. United States, 24 million, and down the line. If you look at the percentage of a population with diabetes, Micronesia, 37% of that population has diabetes. And again, this list gives you some sense of there is a genetic, obviously a genetic predisposition to those who are, let's say, destined to develop diabetes. This is a world map from a few years ago, and on the you'll see the, I don't have my pointer here, but on the left you'll see the darker the color, the more prevalence there is in diabetes. Do you have one? Oh, you do, but I can't see. No. It's all right. That's all right, I could use this. It's all right, don't worry. Anyway, this color map shows the lighter the color, the less of the incidence of diabetes. The darker the color, the greater the incidence of diabetes. Now look at this map, and then I'm going to show you another map over the next 10 years. And just go back, the colors, no matter where you are in the world, are getting darker, which means that... It's here? Oh. It's awfully early. Some of the most obvious things we can't find. So, but look at the colors are darkening everywhere, which just indicates that diabetes is going to be more frequent. And take Europe, again, figures that are up to 8% of the total population. Now here in Armenia, the estimates are that there are 455,000 subjects with diabetes, and again, undiagnosed diabetes in this country about 20,000. This comes from our own place here, the AUA report from a year or so ago, Diabetes in Armenia. The increase of threefold over 10 years to an incidence of 265 per 100,000. Prevalence is increasing. And here's another figure. Right here in Armenia, by the year 2030, 10% of the population will have diabetes. So those are some of the epidemiological features. Let me move on to some aspects of the consequences of diabetes. And again, this is from our own country here in Armenia, from the AUA report as well as from the International Diabetes Federation. The morbidity among children is increased by threefold over the past 10 years. And it's projected that increase in morbidity will go up by about 1% per year over the next 20 years. If you compare this country with a neighboring country north of us, Georgia, interestingly, there is 4.6-fold higher mortality in diabetes in this country than in Georgia, and disability-adjusted life years, again, much worse in this country than in Georgia. Leading causes of death in Armenia, 8% attributable to diabetes, 46% attributable to cardiovascular disease, which may in part be related to the consequences of diabetes. This is data from the United States. The graph shows on the left that this is these are high income, and it talks about mortality versus costs or expenditures in diabetes versus low income cohorts, where you see costs are much less or expenditures are much less and mortality is much higher. Now, I don't know if the data here are actually accurate. I did this calculation, but it seems like the annual health care per person spent on diabetes in this country is $187 US, and it's about 1% of the amount that the United States spends on patients with diabetes. Okay, now we move quickly into risk factors. I can't discuss a lot of the risk factors. Genetics are clearly important. There are certain drugs that are associated, like steroids, alcohol. I will make one comment about smoking. I don't know how to say this as strongly as I should say this, but this country has got to stop smoking. That is absolutely an imperative. And whether you talk about cardiovascular disease, diabetes, obesity, general fitness, if this country continues to smoke, it's going to smoke itself to death. And it's a true point for the men, and it's a true point for the women as well. But I want to move on, though, because we don't have enough time. Let me cover, and Sharon nicely introduced the topic of obesity. With regard to diabetes, and this statement is an exaggeration. I don't really mean this, but I'm going to say it. The three most important risk factors for diabetes are obesity, obesity, and obesity. Richard talked about the double burden in Armenia. We spent a lot of time yesterday on undernutrition. We talked a little bit about overnutrition, and Richard showed a very nice slide that showed that there's more and more overnutrition in this country. And again, it's not just Armenia. 1 billion people in the world today are underweight, and 1 billion people in the world are overweight. Again, remember, there are only 6 or 7 billion people in the world, which is to say that about 1/3 of the population either is overweight or underweight. I don't have to say anything about this slide. You know what this shows. Interestingly, diabetes and obesity are occurring together in the world as the years go by. And in the red is the increasing prevalence of diabetes, and in the yellow, the increasing prevalence of overnutrition or increased body weight, and they're going up in tandem. And these are data from the United States. 1/3 of adults and as many as 18% of youth are obese, and again, these numbers are increasing. And again, diabetes is paralleling the increases in obesity. Again, those who do and who are not diagnosed. Here's another map. On the top shows the diabetes for 2004 to 2010, and on the bottom, obesity. And you can see that both diabetes and obesity are increasing as these colors get darker. The map gets darker, meaning there's more diabetes all over the United States and there's more obesity. This shows trends again from the United States in terms of youngsters, increasing percent of individuals with diabetes going up to 15 or so percent. Now in Armenia, again, the figures, I'm not sure how secure these figures are, but they are published figures, said that up to 15% of children in this country are obese. And this may relate to some of the comments we made yesterday about nutrition. After 1991, diets seem to have changed. Lots of the Western type diet, lots of sweeteners, lots of preservatives, little nutritional value seem to be associated with this. Again, I'm not sure about these figures, but they are published. comparing the United States and Armenia in terms of the prevalence of obesity as you divide it by a BMI of greater than 30, and the figures are very high. Again, 30 to 40% may be too much, but probably not, with 15% of the population of children having obesity. So metabolic risk factors, as the mean body index has gone up, so has the mean fasting blood sugar. Again, these seem to be going hand in hand. Sharon made a comment about exercise. Again, exercise is very good. Not exercise is very bad. And looking at the change in risk of or increasing obesity seems to be related to how much time you spend watching television. 2 hours of television per day is an independent risk factor for obesity, as opposed to an exercise program. Brisk walking 1 hour per day seems to reduce that risk of obesity. So again, besides morbidity and mortality, there are, in this country, not a lot of data with regard to the specific complications of diabetes, such as cardiovascular, peripheral vascular disease, eye disease, nephropathy, neuropathy, all the things that, unfortunately, are in the future of many people with diabetes. But we certainly know that these complications occur as we have data from other parts of the world. And in fact, there are some thoughts about some of these complications occurring even before the patient becomes glucose intolerant, such as microvascular complications and maybe sometimes macrovascular complications. In terms of those with diabetes and heart disease, survival after a heart attack is much worse in men and in women who have diabetes in comparison to the same event in those who don't have diabetes. I'd like to touch upon a relatively newly recognized complication of diabetes, and this relates to one of my favorite diseases, osteoporosis. Now, if you think about osteoporosis, you don't think about type 2 diabetes. It's not on any of the lists. We have many risk factors for osteoporosis, but not diabetes. In fact, many of us think that diabetes is associated with a protection against osteoporosis because most people with type 2 diabetes are overweight. And we know that people who are overweight, in general, have higher bone density. So fracture risk should be lower in people with diabetes than in people without diabetes. But the facts are that fracture risk is higher in diabetes than in those who don't have diabetes. And here are some data that show it doesn't matter what part of the skeleton you look at, the relative risk of fracture is over 1, which means that these people have a higher relative risk for fracture if they have diabetes. This relationship, as we know about bone density goes down, fracture risk goes up. This is a very, very powerful relationship. In fact, more powerful than the relationship between cholesterol and cardiovascular disease. In diabetes, this relationship holds, but it's different. That is, fracture risk starts to go up at higher bone densities. So if you have someone with high diabetes and their T-score is minus 1.8, that gives that person a higher risk of a fracture than someone without diabetes who has the same T-score. Now, I just have a few more minutes. I want to cover in a little bit more detail the AUA report from a few years ago, where there was a qualitative survey, not with hard data, although some of the data were hard, but it was trying to merge data with government policy with the realities of the situation in Armenia. And this is the title of this report. And Vardoui was very much involved in this report, and others. Some of you are here, and I want to give credit to all of you who really did a wonderful job just sort of encapsulating some of the issues with regard to diabetes care in Armenia. It was a scholarly review. I said it was qualitative, looking at 91 subjects, both here in Yerevan and also in a province, Sharaz Maris, which includes Gyumri. And just let me summarize what they found in terms of good news. The good news is that government policies have targeted diabetes for special attention. It's on many, you look in the government policy, every year they say something more about doing something about diabetes. And in fact, there is an infrastructure here for diabetes. There are a number and sufficient numbers of trained endocrinologists and other healthcare providers to meet the demand. There is insulin in this country, and in fact, it is so-called free for distribution to those who require insulin, as is the case for some of the oral agents for diabetes. They're available at the clinic, and even access to insulin is improved. So that's all very good. Not so very good are the following points. Yes, we have enough healthcare providers in this country, but they're all here in Yerevan. Very few are distributed evenly in the other parts of the country. Yes, there are anti-diabetic drugs, but they're not always available, and it's sometimes very difficult to get them. Moreover, if you think about how rapidly the therapies of diabetes are changing, new insulins all the time, there are new classes of anti-diabetic drugs, this country is not keeping up with the changing landscape of the drugs that are available worldwide. The glucometers, the strips, the syringes for insulin, yes, they're available, but they're not always available free of charge, and they're very expensive. Laboratory tests to check the glucose and other aspects are not necessarily available, and if they are available, they're very expensive. And screening for complications of diabetes is really insufficient. So these are all points that need a lot of attention. Is there reason to be optimistic? Here are some reasons why one might be optimistic. The government is attentive to the problem of diabetes. There are dedicated professionals in Armenia and elsewhere advocating for change. That is, those of us who don't live in Armenia are advocating for change here in this country. The specific recommendations of the AUA task force, I think, are very important. And there's a compelling argument to improve the situation. There are so many, and I just touched on a few of them. So there's reason to be optimistic. So here's my sunny, optimistic slide saying yes, but there is much more work to be done. So with that, let me thank you very much for your attention. So I think we're staying on time. That is, we're staying 15 minutes late on time. But now let's move on to the last presentation, which will be Richard Deckelbaum, who's going to be talking about cardiovascular risk factors in children. And adults, excuse me. We're getting good at this. We're going to find Richard Deckelbaum right here. And we're going to find him right here. And
well, hello again. Wow, it's been a pretty special meeting. And I think we're looking at the international scene. We learned a lot yesterday. And yesterday we focused on the undernutrition. Today we're doing the over. And what I want to talk about now is how we might modify risk factors relating to cardiovascular disease, and specifically emphasize, we've heard about exercise, but I'm going to emphasize nutrition. Now, if we look at the projected deaths by cause in high, middle, and low-income countries in 2004, 2015, and what's projected for 2030, and we'll focus here on these blue areas. We can see that even in lower income countries, and I put Armenia here as a middle income country, in 2030, even in sub-Saharan Africa, but especially in Europe and the middle-income countries and the high-income countries, the blue, cardiovascular disease, is going to account for the majority of deaths, both percentage-wise and in numbers in the world. And even in areas where there's HIV, TB, and maternal child malnutrition, cardiovascular disease is going to outnumber all of these other conditions combined. So cardiovascular disease is a major threat and a major cost worldwide now, and it's going to get worse. And if we consider what are the risk factors for cardiovascular disease, we have some that are what we call non-modifiable. So, and we've been referring to this today, genes, age, as we get older, there's higher risk, and the sex differences are actually decreasing because men traditionally had cardiovascular disease at a younger age than women, but women are now actually catching up. But look at this big list of modifiable factors that we can do in relation to cardiovascular disease. So some are related to lifestyle, diet, smoking, activity. We've heard this, behavior and stress. Air pollution, major contributor in many countries. And then the different health conditions that we've heard about today, from diabetes to hypertension, dental disease. So these are all contributors to increased risks for cardiovascular disease, and these are things we can do something about. And we'll emphasize in the next few minutes the role of diet. So there's an interesting phenomenon that even in countries that smoke, like China and Japan, and they go back many years, decades of smoking, that cardiovascular disease was uncommon until plasma cholesterol levels started to increase. So that this is an atherosclerotic lesion just above the aorta. It's actually in a mouse from my lab. So even smoking was not associated with high risk of cardiovascular disease until cholesterol levels started to rise. And if we look at what a major controller, a major culprit in raising plasma cholesterol, and especially LDL cholesterol levels are, it's the amount of saturated animal dairy fat that we take in. And this shows this in children, 7 to 9-year-olds in six countries, that the saturated fat intake is tightly correlated to blood cholesterol levels. And then we can see big changes in different countries that used to have low cholesterol levels, and in the last 50, 60 years, big increases in cholesterol levels. This is an example from Japan. Just from the 80s to the 90s, huge increases in blood cholesterol levels, mainly LDL cholesterol levels. And this was associated with westernization of the diet. And it's not just changing cholesterol levels, but looking at Japan, we can see very striking increases in stroke and in heart attacks from the 50s to the current century. These are huge increases in cardiovascular disease, which are stroke and heart attacks in a population in a short period. And this slide is not a mistake. On your left in blue, and this is data from the 1980s, so this isn't new data, okay? That in the 1980s already, blood cholesterol levels in American children were lower than blood cholesterol levels in Japanese children. And in fact, the Japanese kids' cholesterol levels exceeded the 75th percentile of American children. And in Japan, they had increased saturated fat intake by eightfold in the period of about 30, 40 years. So we did predictive equations, because you can sort of make a guess of how much saturated fat will increase and how much polyunsaturated fat will decrease blood cholesterol levels. And what we found is the Japanese kids had higher cholesterol levels, but lower total fat intake, lower saturated fat intake, and lower cholesterol intakes in their diets than did American kids. But they still had higher cholesterol levels. So what does this perhaps suggest? And this is common throughout Asia. It's common throughout Africa, that when kids get a Western diet, or adults, they may get even higher cholesterol levels than we do in parts of Europe and certainly North America. This brings up the hypothesis, the thrifty gene hypothesis, is that genes that were good in protecting us during times of not enough food may be bad genes when we have normal amounts or too much food. And that increasing total caloric, total fat, and saturated fat intakes in populations not previously exposed will lead to greater and more adverse changes in cardiovascular disease risk factors than in populations long adapted to Western diets. The thrifty gene hypothesis. So we've heard now, we have the new dangers for cardiovascular disease, and both Sharon and John have outlined them, but it's really related to obesity and what comes along with obesity, type 2 diabetes. And this is our typical Columbia University laboratory where I discovered the gene that makes us think that everything's determined by genes. But how many people think we've changed our gene pool in the last 100 years? Okay, you can all stay in the room. So here it is. This is the message. It's the environmental factors, diet and physical activity, that are major contributors to obesity. And we've published now from Columbia over 15 papers showing that even in 2-3-year-olds, that obesity in young children is linked to the same cardiovascular risk factors that adults have, that'll increased risk of heart disease. So even kids who are overweight and obese will have high triglycerides and low HDL, and they carry these risk factors now for an extra 2-3 decades. That means they're going to be in the emergency room earlier, at younger age, with cardiovascular disease. And we've heard some of these, the comorbidities that come along with obesity. We heard about diabetes, but even insulin resistance, the metabolic syndrome, which is associated with these abnormalities, contributes considerably to increased risk of cardiovascular disease even before the first heart attack. And also increasingly recognized is the role of obesity and overweight in liver disease. The most common cause of liver disease now in the United States and Europe is non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, which is associated with overweight, obesity, and insulin resistance. Most common cause of liver disease now in the United States. And I'm sure it's prevalent here. It's probably not being looked for. Respiratory diseases, asthma, mental health problems, and of course heart disease. So if we look at children, even in Japan, and look at the increases in type 2 diabetes, this is what we used to call adult onset diabetes, but it's happening in kids. The purple bars here are obesity in children in Yokohama and Tokyo, and striking increases in 25 years in diabetes. And notice in here in this little box that the prevalence in children of type 2 diabetes is, what is it? 3 to 4 times higher than juvenile onset type 1 diabetes. So it's type 2 diabetes that's even happening in children with the same amount of renal and eye complications as does type 1 diabetes carry. And I'm not going to go into too much detail, but we've compared a sort of a hormone, adipocytokine, that comes from adipose tissue in 2,500 kids in 4 countries. And it's good to have high levels of this molecule, adiponectin, because it protects against type 2 diabetes, it protects against inflammation, it protects against cardiovascular disease. And the very interesting, and it decreases, adiponectin decreases as BMI increases. And the very striking finding is that if we look at adiponectin levels, even in low weight, in normal weight kids, in the United States and in Italy, that the adiponectin levels are higher in Caucasian populations, USA and Italy, compared to the adiponectin levels in Thai and in Japanese kids. And this relationship of higher adiponectin levels continues right through increasing BMI. So there may be some genetic differences between different populations that can account for increasing predisposition to cardiovascular disease at the same BMIs. And this is I think, a very interesting slide. This compares deaths from cardiovascular disease in the productive working group, 35 to 64-year-olds. And at the bottom of the slide here, you see the death rate here in Americans and males and females. Again, Americans, males much higher. But then, look at South Africa, look at India, look at Brazil. 2 to 3 times the death rate in young, productive people than in the United States. So what's happening? In these countries that are westernizing, cardiovascular disease is occurring at a younger age. Okay? For us in the United States, it's mainly over the age of 65, and I think it's going to be the same here. So it's occurring at people in their productive years, and in some of these countries, the major risk factor of taking a middle-class family into lower class is the death of one of the parents from cardiovascular disease. So we've been talking about this, is it genes versus environment? It's genes and environment. And why is Armenia high risk? I don't think we have all the answers, but we've heard some of the statistics. Dr. Sergey yesterday, astounding figures on higher rates of myocardial infarction and stroke here. And I remember 2.5 years ago when I went to the polyclinic in Ichivan, I asked to see the laboratory books, just open. So it was written in Armenian, but someone said, what's the cholesterol column? And someone said, what's the triglyceride column? Oh my God. The percent of people, of course it's a selected sample, but I've never seen such a high percent of high cholesterols and high triglycerides. Armenia is at really high risk. And I don't know if there's national surveys yet available on cholesterol, LDL cholesterol, but just looking at the lab book in a non-Yerevan area, it was scary. So, again, solutions? Do we have something we can do about this? The answer is yes. And diet and physical activity are the cornerstone population approaches. And that's listed here. And I added to this slide what Dr. Bilzikian just said, you've got to stop smoking. And if we just look, and I'm not going to detail these, look at where nutrition can modify risk factors for cardiovascular disease. From plasmolipids to inflammation to ventricular arrhythmias. nutrition has a very big potential role here. And, is there anything we can do to prevent it? You know, we're just watching this epidemic happening. Can we? Should we be doing something? And again, the answer is yes. We heard yesterday that many schools here, many school kids don't even have any physical activity in gym in Armenian schools. Notice these are overweight and obese kids in a gym in Japan. So they're particularly targeted for an exercise and diet modification program. And look what happened in this school over a 3-year period. Both for boys and for girls, no intervention, stayed the same, and with intervention, there was a decrease in the percent of kids that were overweight. So you can do something. But even more striking are the results from North Karelia and Finland, and actually throughout Scandinavia now, where Scandinavia has taken on as major policies of the government, the TV channels, the newspapers, the communities, prevention programs that are working. So if you look here in Finland, this is 1970, 2000, 30 years. Look at the mortality rates from coronary heart disease in north of Karelia and Finland as a whole. Intense changes in diet, going to low-fat milk, exercise, no smoking, and look at the cardiovascular disease death rates. This is heart disease. It was close to 700, and then it was cut by 2/3. 2/3. Part of this is better hospital care, perhaps, but the major part were changes in lifestyle, changes in diet, and it works. And that's the major activity, message we want to do, is that lifestyle interventions certainly can work. And if they can work in Finland, can they work in Armenia? I would say yes. And what our goal here is, in countries, is we want people to die young, but at very old age. Thank you very much.
We do have time for questions, I'd like to start with asking Richard a question about this concept of thrifty genes. In the United States, when the United States developed a Western diet, because at one point the United States didn't have the so-called Burger King diet, and then developed the processed food diet, then we had huge increases in cholesterol and cardiovascular disease. And then the Westernization then settled down, and now we're seeing an adaptation. So I'm wondering whether that's a specific genetic feature from country to country, or what would happen to any country, even the United States, when it was first exposed to a Western diet.
I think the concept of the thrifty genes interrelates with total calories available. And so that in nations that were exposed to famine, or populations that were exposed to decreased food intake, actually insulin resistance is protective in terms of survival. And so you have selection of people that have these genes that will promote insulin resistance in times of low food availability. And that was actually a survival, good for survival. And then when you get enough, or even normal foods, this genetic selection, I mean, that's the hypothesis. It's still a hypothesis. Sharon?
The other aspect is when there's a mismatch between the intrauterine environment and the options that are the baby's born into. So the small for gestational age baby is at the greatest risk. And so there are thought to be adaptations intrauterine that are adaptive intrauterine, maladaptive if they're born into an environment with surfeit. And that's where you see the biggest mismatch. So the thrifty gene kicks in most aggressively then.
That's an important point. Let me just tell you one interesting hypothesis I learned from someone from Cooperstown Hospital up in Bassett Hospital. So blacks in the United States are much more salt sensitive than blacks in Africa. So if you give an African American high salt diet, they'll get a bigger increase in blood pressure than will a African in Africa. And the theory, hypothesis is that when they took the Africans on slave ships and they got diarrhea and they, because there was a high death rate on the slave ships transporting slaves from Africa to North America, that salt retention was a benefit for survival. And then they get selection for the genes that are associated with salt retention. So there's certain types of things that may be good for survival under one circumstance, and they're bad in terms of risk in another circumstance.
I just want to also add, I'm going to ask myself the question. Kim asked me this morning, why, if obesity has so many risk factors, why is it not selected out? And so one response is, it's only been in existence at the rates that it has in the last 100 years. Throughout our evolutionary history, all the things that make someone susceptible to overweight and obesity are actually the genes that got us here. So when Rudy Leibel starts teaching, he brings out the point that food, water, and air are emergencies. And throughout our evolutionary history, food wasn't as readily available. And if our blood sugar went down and we passed out, there wasn't fast food around, our mother wouldn't necessarily bring us food. So there are many, many, many systems that we have that when we are in a negative energy state, we said from the 400 to the 360 or the 100 to the 90, when the body perceives any negative energy state, it perceives that as an emergency. And all of the signals, get food, get food, get food, it would be as though I reduced air from you. All the signals that say, get air, it's an adaptive thing, it's seen as an emergency, and it's all the genes that got us here.
Yes. There's a microphone coming to you quickly.
Thank you very much for very comprehensive presentations. I have a couple of questions. And the first one is, what about gene modified product? Do you have any research that prove role of gene modified product to development of obesity? The second one is about what about role of calcium in decreasing of obesity? Do you have any study that shows the role of calcium intake in decreasing the obesity development? And another question about low birth weight infant and very low birth weight infant. Do you have any study that shows that they have in future the obesity in adult age? Thank you.
I'm not aware of any connection between what we call GMOs and genetically modified foods and increased obesity risk. In the United States, well, maybe there is because, well, Europe, where there's big increases in obesity, they don't allow genetically modified foods in many countries. It's still happening. In the United States, where 75% or 80% of the food is genetically modified, it's happened. But actually, the obesity rates now in the United States, at least in children, may be plateauing, or even there's some early suggestions that in some areas it may be decreasing.
One of the questions was calcium and obesity. I'm not aware of any relationship between calcium and obesity. There is a theoretical thought here, and I think I understand what you're asking, but I don't think there's any evidence that would relate calcium to obesity.
And there were a series of studies in the last 10 years with dairy and weight, and they've all been basically shown not to be. Originally there was some observation that dairy could help with weight loss diets, but that's not been able to be duplicated. The last question was about low birth weight, and I think, Eugene, would you like to take that? I think it has to do with rate of weight gain, right? Are you going to talk about it?
Yeah, I think there's a good amount of evidence suggesting that prematurity and low birth weight, indeed small for gestational age, later on results in increased obesity risk and increased risk of diabetes, and that has to do again with the turning on of the thrifty genes, right? And it really depends on how the fetus perceives the intrauterine environment. So if there's any kind of placental insufficiency, whether you're premature or you're not premature, then infant perceives that, or the fetus rather, perceives that as starvation. So the fetus says, okay, when I'm going to come out, I'm also going to be in the same environment. I'm going to be starving. So the fetus turns on certain genes to increase the likelihood of reproduction before starvation. One of the things that happens then is for example, the less development of the beta islet cells in the pancreas. So the likelihood of diabetes in the fetus, when the fetus is born and becomes a person, increases. So yes, there's a relationship clearly.
And Sharon mentioned earlier this morning epigenetics. So epigenetics is when you don't change the gene, but you modify the gene by putting on, let's say, an extra methyl group, a carbon group. And a Columbia group, together with a group in Holland, showed that after that, the survivors of the Dutch famine, so in World War II, the Germans put a famine of 9 months on Holland, to punish Holland. And after that famine, when the adults grew, the survivors who were born during the famine, went through gestation during the Dutch famine, they looked at their genes, and they found that there's a gene called IGF-2, insulin growth factor 2, which predisposes to metabolic syndrome, type 2 diabetes, that there were big changes in methylation of this gene as a result of intrauterine starvation during the Dutch famine.
Yeah, interesting, by the way. They tried to replicate this kind of study in Leningrad, with the blockade of Leningrad. I'm sure you're familiar with it. And they weren't able to do it, probably because too many people died. Too many.
Other questions?
I think if not too many people died during the Armenian genocide, maybe we could try to find such a relationship. Thank you.
We're sorry to have so many examples.
About 5 years ago, Bertie Lumet at Columbia organized a conference on famines. First of all, the interesting thing that came out, there's no such thing as an apolitical famine, but Ukraine had a famine, Sweden had actually famines, and the interesting thing is when you look even at the grandchildren of famine survivors, they have increased, not everywhere, but they have increased risk of cardiovascular disease risk factors. Sorry, you can't hear?
մեր գենետիկայի ինչպիսի փոփոխություններ են տեղի ունեցել եւ որ հիվանդություններն են հատուկ հատկապես հայ ժողովրդին։ Բացի նշված սիրտանոթային եւ այլն, որ հիվանդություններն են հատուկ մեր գեներին։
Yeah. So, yeah, the disease that everybody thinks about that is not specific to the Armenian people, but to the Mediterranean, the Greeks and Turks, is familial Mediterranean fever. So there is a genetic disease that is more prevalent in the Armenians. Do we know others? Do we?
But I can add actually to that because I worked in Jerusalem for 10 years. And I saw a lot of familial Mediterranean fever. But when the Jews got FMF and the Arabs, and then the Arabs and the Armenians, because there was a big Armenian community in Jerusalem, the risk of getting amyloidosis was highest in the Armenians, second in the Arabs, and lowest in the Jews. So the FMF expressed itself differently in terms of its complications, in terms of its major complication, which is amyloidosis. It was especially bad in the Armenians.
Okay, do we have time for another? We have time. We have time for a few more questions, yes.
Thank you for very interesting presentations. I have two questions. One, the interrelations between the duration of sleep and epidemics of obesity, especially in adolescent and young adults as well. And the second question is development of appetite and taste preferences in children, how we can influence maybe to prohibit early introduction of sweets or salt. What can we do?
So you should hear because the literature on sleep is very important, and as with a lot of observations with obesity, we don't know what's a cause and what's an effect. So in some cases, at certain levels of development of obesity, there's sleep apnea, there's poor sleep, and it's probably a vicious cycle. The poor sleep leads to behaviors that lead to greater eating, and then they keep going up. There's a researcher in our group, Dr. Marie-Pierre Saint-Onge, who's studying this in children, and in general, there's enough of a consensus now to say that we think too little sleep is causal, but we don't know exactly how. So the short answer is we think too little sleep is causal, and then you have to take a step back and ask why the person's getting too little sleep. And maybe there's a combination of factors, and that's where you want to intervene. And because that's important, because if it's a different factor leading to the change in sleep, just changing the sleep may not lead to the factor that's ultimately causal. The question about childhood feeding and when to introduce sweet foods is one of the most important questions, and it's important for appetite, and now we understand also the importance of the microbiome. So I'll let Dr. Deckelbaum talk about that because he's a GI person. We have I won't make any of the jokes that we usually make about that, but I'll let him touch on that. So independent of appetite, the foods and the effect on our microbiome is very important.
Just one short comment. It was interesting. I showed slides from my collaborator, Dr. Kita in Japan. But one of the interesting observations they had in Japan relating to sweets and things is that when the children eat a traditional Japanese diet, the caloric intake was much less than when they eat a Western diet. And in this town where he worked in Matsuyama, I've counted in a 26-minute drive from the airport to the medical center, 19 McDonald's. So the shift, and in terms of the microbiome, so the microbiome is the bacteria that we have in our intestines, and there's really a very exciting and it's a developing field, but in New York we have the pleasure of associating with someone called Martin Blazer, who's just actually published a book called Missing Microbes, and he writes that the overuse of antibiotics in children changes the bacteria in the intestine to a family or families of bacteria that are associated with much higher risks of obesity, type 2 diabetes, etc.
So also just to add, in general, sweets, fats, and salt, what my son calls junkification of food, as most of your food as it's grown, and once it's processed, just for us to be able to eat it, it doesn't have concentrated fats, doesn't have concentrated sugars, and not salt. When we process the food, that happens. At every age that we're introduced to higher sweet, higher fat, saltier foods, we grow to prefer them. So we see that in animals, we see that in wherever those kinds of foods are made available, the natural inclination is to eat them, and we could go into the reasons evolutionarily. Usually sweet came along with a safe food, bitter came along with a food that was toxic. So there are many reasons at every age to be concerned about the amount of sugar in the diet, and now there's new work on the addictive components of sugar and fat. So I would recommend following that literature, and I would recommend staying with the pictures we saw yesterday of the Armenian food.
Yeah, I think that was a very comprehensive, good explanation. The only thing I want to add is this, as far as sleep, there's now data about correlational data for obesity and sleep in very young children too, even going down to 3-year-old children from somebody named Elsa Tiveris. So it's probably at all different ages. As far as the developing food preferences, it's a combination of genetics and it's a combination of environment, like everything else. So there's some children who have, I believe, have preferences for sweet, more so than others. You know, some children who eat when they're not hungry, other children who are less likely to eat when they're not hungry. And so when we talk about breastfeeding in a little while, we'll have to touch on that a little bit more.
I think, is there one more question? We'll take, oh, we have a lot of questions. I think we're, all right, well, yes, Sergey.
Thank you very much. Just we have really enough fruitful discussion. Just we haven't discussed yet one factor which could be some kind of modifying factor for just everything what we discussed over these 2 days. It's about altitude over sea level, because in Armenia we know that altitude over sea level varies from 386 meters to 4,090 meters. And when we look at the data of cardiovascular morbidity, we do know that, at least there are some studies that when we go up, so morbidity that cardiovascular should decrease. Yes, it's why some data regarding, for instance, for ischemic heart disease from the States was, as I remember, and respiratory, like COPD increase, and also what we know that birth weight of the children, when we go up, when we go to the mountains, it decreases, as I remember, like for 500 or 1,000 meter, 100 grams or something like this. Yeah, so just do you think that really in Armenia we have some modifying effects of altitude in Armenia on these topics?
Yes.
The answer is yes.
But you'd have to confirm, it's confounded if each of the things you mentioned is multifactorial, right? So depending on, if you start adding the things that will increase risk, you'll be even higher risk. And by starting at high altitude, there are some ways in which you're at even higher risk. So in terms of interventions, the challenge would be, right, if the birth weight is much lower as we go up, the challenge would be to target weight gain during pregnancy and see if there's something that can be done. The index of suspicion just keeps going up with each of those risk factors.
I think we have time. Is there one more question? Yes, one more question.
Thank you. I'm Henrik Hachatran from WHO Country Office here in Armenia. First of all, thank you for organizing this important workshop. And today's topic is very important, the NCDs and the life course. And as you know, WHO is stressing this every time. I have a short question to Sharon regarding the pregnancy and obesity and overweight during pregnancy. Do you have a special advice and special diet for pregnant women who have overweight in the US, or it's the same? Or do you try to control the weight during the pregnancy in the United States?
I got nervous when you said short. Now I'm even more nervous.
Thank you.
It's a very, very, very important question, and we don't have any magic. Right? We don't have any magical solutions. We have approaches, and most of them look at ways of helping the woman change the home environment. Because in the United States, the opportunities for free and poor nutrient but high calorie foods for the women at highest risk of developing gestational diabetes is tremendous. And Kim and I do a project with our class at the beginning to have them go out and look in the neighborhood and see the foods that are available on a very low budget. And for the most part, if you're trying to stretch your dollar and you focus on calories, the foods that the person is going to eat, the pregnant woman, are the same ones that are going to ratchet up her weight very quickly. So at the very center at Columbia, they try to work very early and very aggressively with looking at the blood sugars and seeing ways with physical activity, with helping her look at how she should select foods and try to follow the weight gain extremely carefully. There's no one diet. Most of them have to be culturally sensitive, specific to the socioeconomic status, and working with the individual on basically a patient-centered approach. I think the common message is the one that you're asking, which is to intervene as early as possible, to help the mother understand that her food choices and physical activity choices are going to affect her baby and her grandchildren. And some of us see that as what's called a teachable moment, that it's an opportunity to help the mother influence her child, and usually that's a time when most women are extremely motivated. I understand that smoking goes down to almost zero with women during pregnancy. That happens in the United States also. So it's an opportunity as much as it's a challenge.
I just want to add, in the United States, 60% of pregnancies are not planned, so they happen. And there's a saying that we had when we had a task force on this, is that women need to think of every day for some day, preconceptional, periconceptional women. Every day for some day. So we know that folate status, for example, has to happen, if it's going to have effect on neural tube defects, it's preconception. The other underappreciated thing, and we saw the data on women in Armenia yesterday, which is very scary, is that women who are in the overweight BMI or the obese BMI class at conception have, and I think we mentioned it, much 2 to 3-fold higher risks of having babies with major congenital anomalies or combined congenital anomalies. So we really have to get that as part of education, that women are endangering their babies by not being ready for pregnancy. So,
Two quick comments after that. So if the woman's already overweight, focusing on that is very important. Nobody focuses on helping women lose weight after pregnancy, and that's kind of a void in the United States once the...
Okay.
We're going to stop after this. So the weight gain, weight loss after pregnancy is very important. And Dr. Dinkiewicz just reminded me to emphasize moving, being physically active during pregnancy, very, very, very important. So.
Okay. Well, thank you very much, Richard and Sharon, for this very stimulating first session of the morning.